welcome everybody. It's great seeing everybody back in person and being able to do this. So we'll go ahead and get started. So there's only been 12 of these, I think, if I counted right, if I didn't run out of fingers to count. So I think you guys know how most of this will go. We'll talk a little bit about the numbers. They don't look so bad right now. A lot of the other stuff are things that we can refer back to some of the other talks. I'll kind of hit the highlights, but for a lot more detail, you could see in some of the other presentations that are recorded on the website. Guidance, get vaccinated. You heard all the data. It doesn't hurt, and it only helps. Monitor the situation, assess the risk. We'll talk a lot about this, and find a balance between risk and living life. You know, being a provider over the last 2 years in this pandemic, we've seen sort of this huge balance of people that are either clustered, sequestered at home and not leaving, getting deconditioned and not doing things, and people who are completely ignoring it and don't think it's real. And kind of like in life and in politics, like somewhere in the middle should be kind of where we try to get at. So with that, we'll kind of talk a little bit about where you might fall in that spectrum and how much to push it one way or the other, hopefully. So where are we at now? This is the US, New York Times. You guys have seen these graphs. In the US, you could see the huge Omicron peak that we're just kind of got past. And you'll start to hear a lot about like, oh, we gotta be careful, the numbers are going up. Yes, they're going up, but look where we're at. I think we're in a really good place. We still have numbers that are much lower than we have been throughout most of the pandemic. The numbers in the US have gone up 50%. Again, this is one of those where sometimes by percentage it looks impressive just because we dropped so low, and this is almost just barely higher than we were at last summer, okay? So I think we're doing in a really good place, and if you look at sort of hospitalized, ICUs, and deaths, especially these bottom numbers, we're still kind of in a really great place and kind of coming down from these numbers. For comparison's sake, this is kind of where we're at again compared to the last update. So just to provide a difference, dark red is bad, not so bad. Colorado does have a few counties that, you know, could do a little bit better, but overall we're doing really well compared to what we have been in the past. To drive the point further about vaccinations, if you look at currently a mortality rate in Colorado, and you got to think that most of this really was probably pre-vaccines being available, right? This is the mortality rate through the entire pandemic, is that you can see that the rates are highest on the Western Range and on the Front Plains. When you look at the vaccination rates, they don't match up perfectly, all kinds of exceptions, but overall the pattern looks kind of like the opposite. If you look at this for the Delta variant wave, the Omicron waves, these still hold and actually just get cleaner because the vaccines were available as opposed to the Alpha variant, that first variant that was there. When we look at Colorado numbers, our numbers are actually on decline. And I think part of that's because we saw that they were kind of coming up a little bit ahead of the curve in the rest of the United States. So locally, even though we kind of look at the United States and we hear that the numbers are up, we have to look at our numbers, right? We're not going to get COVID from somebody in New York City. So our cases are coming down. Vaccination rate, we're at goal, 70%. So I think we're doing pretty well. And especially if you look at a lot of our counties around here, we're doing really, really well. All right, so this is where we were at. I don't have a crystal ball, but these guys have what comes closest to it. We've seen the data before in prior presentations. And we can see that the number of cases is predicted to kind of stay really, really low throughout most of the summer. This goes out to August 1st. And so when we look at the numbers, I don't want to say smooth sailing. The crystal ball doesn't always work. But it gives us a sense that I think we're headed into a pretty good, calm rest of the summer. And again, we got to keep paying attention. But it gives us a really good light at the end of the tunnel. Now, we know that these viruses like to come out kind of like the flu and the other cold viruses. Remember, coronaviruses aren't new. They've been around for a long time. So the 4 major strains tend to come out in the winter months. Gives us a sense that we may be okay until the fall or the winter, okay? When we look at hospitalization use and ICU use, the two different curves, the top one's hospitalization, ICU is low. it kind of matches that up, and it shows really sort of where we're at, where our numbers are lower than they have been throughout the entire time of the pandemic. All right, let's talk a little bit about variants and see where we've kind of been at. Okay, so we got to remember that with the vaccine, that most of the vaccine has really come across against the original alpha variant. This is the dark blue here. And you can see that there was other little variants that kind of came and went. It got replaced over a few months into the Delta variant that kind of was built out in here. This is the Omicron variant. And I think the impressive part about the Omicron variant is that really within a month, it completely took out the Delta variant. As we're starting to kind of look at now we're starting to kind of talk about the B2 variant of Omicron, and we're starting to kind of see this other new variant kind of pop up, the BA2.12.1, just rolls off your tongue when you're talking about this stuff. So I think as you're looking at this stuff, it's important because one of the treatments, as we start thinking about it, is really dependent on how well that antibody works against some of these things. And we'll talk a little bit more about that. But remember, right now we're looking at the BA2 variants, and the BA1, the original Omicron's almost disappeared. It's important to remember that these variants don't necessarily hang out in small numbers, that they really just come and go. I don't remember hearing about Epsilon, but this was one of the variants that came. And just because you could play with it really nicely at this website, if you get really curious about it, is you could see, that it kind of came, kind of went away, maybe, and then kind of hung out a little bit, and then just kind of really disappeared. But we're really not seeing the alpha variant much, these kinds of things. I mean, they're completely gone. All right, so let's talk about risks for MS patients. So age becomes important. We hear a lot about age, and we will kind of break some of these down a little bit more. So males, we have more issues. Getting COVID is one of them. I should say getting bad COVID is one of them. Comorbidities. So we've heard about heart disease, lung disease, diabetes, being obese, cancer, some of these other things. I'm going to highlight that this is the big one, disability level. And I think this is one of those things that we don't talk a lot about, but we've seen that the risk with this, outside of even COVID, lung infections, urinary tract infections, and especially in RMS patients, as you start to kind of get wheelchair bound, that this becomes a bigger and bigger issue, disproportionately to almost anything else we're talking about. And then we'll talk a lot more about the treatments. So this is the North American data. There's a bigger data set that includes this data. This data makes about over half of kind of that other data, but just for simplicity's sake, just putting in this data that I've shown before a little bit to highlight, again, some of these numbers. So again, when you look at, we can look at hospitalizations, you can look at ICU, ventilator, and you can look at deaths. And I'm going to concentrate mostly at the death side because we hear a lot about this side already. But when you look at the risks of death as age goes by, and you got to think this is every 10 years, so it's not quite the same if you're 70, 60, each of those time periods goes up by 1.7 times. So it's a risk factor compared to being a man, maybe a small risk factor. When you look at a lot of these other cardiovascular things, you're talking about increasing by a risk of maybe 2 to 3-fold. The biggest ones are looking at this cardiovascular over really lung disease, high blood pressure, and being obese. So when we kind of push this time about like, hey, this is a good time to kind of start getting exercise and these other things, those are the things that you can actually help with trying to reduce your risk. It's really hard to go from a man to a woman. I'm not sure we can do that yet. And the one I keep trying to do is try to get younger, and I can act like I'm 21, but unfortunately, I'm not sure that changes my risk much. All right, this is that disability level. So going from needing to have a cane or a walker increases your risk by 3-fold, a little bit, in line with some of the other things. If you're non-ambulatory, like pretty much stuck in a wheelchair, bedbound, those kinds of things, look at that number. 25-fold higher risk. So these are the patients that when we start to talk about what are those extra things that we need to do to protect, who needs to be careful about going outside, who really should be wearing their mask, those kinds of things. We really should be thinking about this population. When we talk about drugs, when we look at the death rates, none of them are really significant. Rituximab goes up a little bit. Part of the risk with rituximab is usually rituximab is used kind of in end-stage MS when you look at outside of our center. And so these are patients that a lot of time are very progressive, very advanced. And so that's the one drug they can kind of go to. So some of these numbers are influenced by some of these other numbers. When you look at hospitalization rates, you do see that ocrelizumab and rituximab have a higher risk of patients going to get hospitalized, but it doesn't seem to translate into the death rates. And we might be able to speculate a little bit about this, that this might have to do a little bit because when you're at that end stage of COVID, you release a lot of chemicals that the body just doesn't know how to react. It's just overwhelming. And if you control the immune system at that point, that it actually might be beneficial. And that's a little bit of data that came around with tocilizumab being approved for not a EU emergency use authorization for COVID and things like this, that are treatments that we use for other autoimmune conditions to try and lower the immune system because it's been helpful at that stage for MS. All right, so layers of protection against COVID. This was some marketing data, but it looked like a really nice slide, so I stole it because I think it provides about other stuff. And I think, you know, there's the prevention stuff. We've talked a lot about wearing masks, social distancing, practicing hand hygiene, all these other things that prevent you, you know, if you stay away from people, it's hard to get it from people. We can talk about vaccines, boosters, double boosters, triple boosters, you know, we'll see kind of where we end up at now. Long-acting antibodies, which is the Evusheld that Dr. Piquet was mentioning, because these can help prevent. Basically, these antibodies will bind the virus, and then the virus can't infect cells because basically it's covered up with all this other stuff around it. All this other stuff also lets cells absorb this virus and kind of destroy it and kind of handle it and get rid of it. And so these are the things that that we can do to try and prevent from the infection from really trying to establish. And we'll talk about treatments a little bit later. Who's eligible to get Evusheld injections? So not currently infected. If you're already infected, it's kind of hard to prevent it. So, I mean, that one makes sense. Some of these things make it a little bit tougher, right? So if you can't get the vaccine, this provides some protection. If you you have to be some immunosuppression because the vaccines were deemed to be so good that to some extent, if you had a normal immune system, it wasn't worthwhile getting Evusheld. So if you have risk factors, basically, and this is kind of what this is kind of getting at, the last 3 bullet points, whether it's HIV, cancer, iron immunosuppression, those kinds of things, then you're eligible to get Evusheld. So again, most of our patients are eligible to get Evusheld. For us, really, the risk factors, as Dr. Piquet showed in her table, was basically the S1P drugs and the CD20 or the B-cell depleting therapies. All right, so this got approved in December. Not approved, emergency use authorization. A new dosing became available in February. This was kind of the increase in dose. It really, for us, became available in March, early April. We knew of certain health systems, like Aspen got extra doses, and some of our patients in their system were able to get them earlier and things like this. In our center, it really went towards cancer patients who basically were on drugs that took out B and T cells and had a much harder time getting responses. And we started to kind of get doses about the end of the Omicron wave. And so at that point, how helpful that is, we'll talk a little bit about. Basically, what is it? It's basically a combination of 2 antibodies. I'll let them read them because I'm not sure how to pronounce them. And they're approved for adults or kids that are 12 and older who weigh at least 40 kilos, think about 88 pounds, something like that. It's 2 intramuscular shots in your butt is mainly the main place that you get them. And then they watch you for an hour. It is contraindicated if you have an active infection, again, because then it's not going to be helpful. Or if you've had the COVID vaccine within a couple of weeks, you want that vaccine to kind of do its thing. Bleeding concerns, again, if you put a needle into somebody who's going to bleed out, you probably don't want to do that. So, I mean, some of these things are common sense. And cardiovascular risk, there's a very small increased risk that they have seen with people who have heart failure, of chest pain, and things like this with these things. That risk is small, but that's the reason for watching you for the hour, because most of these things happen really fast. One of our nurses is actually working in the vaccine clinic. As far as I know, there's been none of these cases or concerns so far at UC Health with this. So again, a really small risk. All right, so these are preventative antibodies, but what if you get COVID, then you can use antibodies to help try and take care of the infection. So this is, I think, is kind of the main treatment that we have seen for COVID throughout the entire pandemic. And I'm going to start from the bottom up a little bit, at least initially, because at first we didn't have these monoclonals. So the first availability for these was convalescent plasma, meaning people who got sick, recovered, they would take their antibodies and give them to other patients that were sick. Basically, IVIG sometimes is the other name, but specifically from people who had had COVID to try and enrich for antibodies that might be preventative, protective against COVID. Again, when we look at this, who qualifies for this? These are patients that have not yet been hospitalized, because you're kind of working early, right? If the infection's established itself, the antibodies aren't going to help too much. So you want to kind of catch it while the infection is getting going. So not hospitalized within 7 days of the infection, and they should say do not need oxygen. Again, you want to catch it early for these monoclonal treatments. We've had a number of these come through. These first two were kind of the early ones. These are no longer really emergency use approved, because they no longer work against the strains that we have. So this has kind of been an evolving field. This one's the one that we were running out and got left with for the last Omicron wave. This one is now no longer available, because it's not effective against the B2 variant of Omicron. So what are we left with? We're left with this one, still effective and still looks really good. The data on Evusheld is that it should work against the variants, the new variants of Omicron as well. So those are the two and the types of two antibodies that should work really well for this. All right, so what are the treatments? So really early, we were able to use remdesivir, because it was available already for other viral infections. This is an IV treatment. This one's reserved more so for patients that are hospitalized, and basically it prevents the making of RNA for the virus. As it replicates, it stops that process of the virus RNA making protein from being able to make RNA. And so this one is approved for sicker patients as the infection gets more set up. And so this is mainly reserved for hospitalized patients. Paxlovid is really the big one that we have not been able to take much advantage of, for good or for bad. The good is that I guess the bad is it only came out, got approved not that long ago. It says December, but really it didn't become available until end of early April, end of March. We started to get our first doses kind of again at the tail end of the Omicron wave. And so we've had several patients get it and do really well with it. This is a combination of two medicines. You take 2 pills of this one pill of this. You do that in the morning, you do it at night, and you do it for 5 days. The data for this is like 90% plus reduction of mortality in patients who take this. And you want to look at it within 5 days of symptoms. So you want to try and get in early for this treatment. Approved for adults and kids, again, who weigh that 40 kilo mark. And the biggest issues with it is you have to adjust the dose if you have kidney damage. And for patients who have severe liver damage, it's contraindicated. It does interact with other drugs, and I can tell you from patients that have called in the hotline to try and get this medicine from the urgent care clinic, is that I think this is scaring the use of this medicine some. A lot of our drugs are processed through this liver enzyme. a lot of drugs that you might be on, carbamazepine, oxcarbamazepine, so Tegretol, Trileptal, um, birth control pills, things like of that nature. So these are commonish enough drugs that you do have to kind of run through your drugs and make sure that it's not an issue. But again, most of the times you're only doing this for 5 days, so you can stop birth control for 5 days. Spasms, bad COVID, I think we can take, this for 5 days and hold off on the other option as well, and these kinds of things. So I think there's ways to do this, and I think this is a huge advantage. All these drugs work against all the variants. I'm going to skip basically this last one because it doesn't work as well, and hopefully we have lots of doses of this other one so we can skip it. So what should we do? Get vaccinated. If you can prevent it, it's that much easier. It works well. Again, we're vaccinated against the alpha variants, and it's protecting us against even the Omicron, all these other variants. Because you're getting farther away, the extra boosters do seem helpful. It does seem kind of crazy that we're recommending 5 shots now for some patients. I'm going to review that a little bit. So remember, because I'm still getting a lot of questions this in clinic. So the vaccine series for patients on B-cell depleting therapies and S1P inhibitors is not 2 shots, it's 3 shots. Super important to remember that, because if you've done 3 shots, you still need to get a booster. And now they're recommending booster number 2 if you're over the age of 50. So that gets you to 5 shots. We're in a better place, let's put it that way. All right, so what's the risk? So I think this is kind of, again, not that you're going to put numbers and figure out exact numbers, but things to consider as you're putting this. So you have to look at the rates of COVID. If the rates are high, middle of February, half my clinic had it. I got it. I think it was one of those things that, it was everywhere. Okay. And so trying to figure out if it's high, you're going to be more protect. You should take more precautions. If the numbers are low, you can take it easy. I don't know how else to put it, but it's kind of how much spit are you going to swap? I mean, that's the ultimate goal of what you need to think about. Obviously, if you're kissing family members, that kind of stuff, living with them, the risks are really high. Okay. But trying to figure out, should I wear a mask when I do this or that or other things? Okay. These go into the factors of like trying to kind of get a sense for where you're going to be at as far as risks go. So indoors or outdoors? If it's outdoors, is there a lot of wind that's going to blow that air around? Or is it going to be one of those hot, humid days where the air is just going to sit there and just basically as people talk and you're spitting, it's just going to sit in the air? That's how it spreads, guys, right? So, I mean, we have to think about it that way. How many people are there, right? Did you go to your favorite rave with, 1,000 of your closest friends and are kind of like standing shoulder to shoulder with them? Or are you kind of in a much more socially distant type of an environment where there's less issue, right? We worry a lot about airplanes, but airplanes actually filter the air and they turn over the air a lot more than pretty much anywhere else you're going to be. So it's probably one of the safest places. You're probably more concerned about the airports than you might be at the airplanes. So those things, again, are the things that, we have to think about. How much time are you going to spend? Am I running into the grocery store for a 2-minute thing, or am I going to go in for an hour and get all my week's supplies? Am I going in at 6 o'clock in the morning, or am I going to go, 5 o'clock when everybody else is going? More people breathing that air out, putting more spit in the air. Masking, are you wearing a mask or other people wearing a mask? All those can reduce the risks a lot. So these are kind of factors to think about. And then what is your risk should you get it? So things like, what drug are you on? Most drugs for MS are fine. Most of the drugs we use, maybe not so much. We like those B-cell therapies, the S1Ps we use a lot, those kinds of drugs. Those risks, again, are we talking about hospitalization rates or are we talking about death rates? Death rates doesn't look terrible. Hospitalization rates, again, wheelchair, not wheelchair. Those things you have to kind of try and weigh for yourself and see where you fall in. And then kind of comorbidities. You have a lot of heart failure, bad COPD or diabetic, out-of-control diabetes, not well-controlled diabetes, those things. And trying to kind of put all these numbers in. Once you figure out your risk, we can't quite wrap you up in bubble wrap. Okay. And so you have to kind of be able to get out and do things, because it's important for us as social beings that after 2 years, You know, you can lock yourself up for a little bit, but after 2 years, you need human interaction. We're social beings, and locking yourself up. Now, some people are more introverts than extroverts, and as an introvert, you might do much better than somebody who's an extrovert. Okay, as an extrovert, you might want to figure out ways to reduce your risk, right? Those kinds of things. But I think you have to balance those things out. It's time to go see people. It's time to do those things, right? And so that's that main point of like, it's time to get out of the house, exercise, eat right, and be overall well to kind of be thinking about things. So with that, I appreciate it. And I think we're headed over to Q&A.
Break.
Break, guys.